So good evening, everyone, and welcome to the fourth and final episode of this series discussing the direct anterior approach to the hip. So in the first episode, our panel of experts covered the pros and cons of the technique, and we then took a deep dive into the literature on the subject, led by the academics within the faculty. And last week, we heard some very interesting discussion on perioperative aspects and some controversies respecting the important roles and views of anesthesiologist and a physiotherapist in striving for the best possible outcome for individual patients undergoing this procedure. Tonight, we explore the nuances of the different surgical techniques used by members of the panel. And our panel this evening is led by Dr. Chuck Chuckage from Fourways Hospital in Johannesburg. We have also Dr. Johan Botha from Morningside Clinic in Johannesburg, and Dr. Jan Hubert from Panorama Medical Clinic and Stellenbosch this evening, and Dr. Henny Bosch from Durbanville Medical Clinic, Dr. Hein de Jong from Panorama Medical Clinic in Cape Town, and Dr. Koos Jordan from Tygerberg Hospital. So a lot of experience within this panel this evening, and we really look forward to hearing their views on the subject. So just to remind everybody, the intention of this four-part series was to share best practices and lessons learned among South African surgeons interested in the subject. And it is hoped that this group, including you, the audience tonight, will connect to build on this virtual event and carry the momentum forward in the interest of ongoing education, enhancing the learning curve, and never losing sight of achieving the best possible outcome for the patient. So our faculty, led by Dr. Koos Jordan, has participated on an entirely voluntary basis, and they must really be commended on their enthusiasm and their commitment to this process. The Advanced Orthopedics team are really proud to have been associated with this academic initiative, and we look forward to supporting further education on the subject in the future. And with a little luck, we'll be able to meet face-to-face early in 2021. So enjoy the evening, and I'll hand you over to Dr. Chuck Chuckage from Johannesburg. Evening, Dr. Chuckage.
Good evening, everyone. Everyone who is listening, I'm honored to be a chair of this last episode, the fourth episode, but I promise you this is a last episode of the first season. And season 2 is going to be broadcasted very soon in the future. I promise you that. We're going to work on it. And because this is an amazing initiative which mustn't die, it has to continue. So today we have a very strong panel of speakers, because there is a different ways how to actually perform DAA and how to skin the cat. So we're going to listen to different approaches to DAA. But before that, I'm taking a privilege of being a chair and share with you 5 points of safety, how I'm seeing it. For two reasons. First of all, because I want to share this with you. And the secondly is I wanted to engage that 5 points with the panelists later on in a discussion to see what the other people will think about 5 points. What would be the 5 points of safety in their own practices and their own hands? So I would like to share this with you. So the first point of safety in my practice is the templating. I think that is extremely important, especially in an anterior approach. And this is the two examples of patients who are preoperatively screened and templated on a system that I have in hospital, which is a part of radiology department. One is a unilateral and one is a bilateral procedure. So I think this is extremely important in any procedure. Doesn't matter what approach is used, but in anterior approach specifically. In specific cases, they are very, very difficult. There is an option, and most of the companies do have an option. If you send them your pre-planned CT scan and x-rays, they can actually help you out to reach the point of better success in the surgery. Just as a hint, what can be done with any procedure, as we know with the knees mainly, but in the hips as well. The second tip for me is a backup system. What I mean by that is that I don't start operation if I don't have a scenario A, B, and C, at least in operating room. And you can see on this picture on the left that same patient in a period of 4 years had an uncemented and cemented prosthesis. And obviously that was planned, the second cemented hip was planned as uncemented, and the decision to change was done intraoperatively. Also, the problems can happen anytime, so you have to have a backup system, like in this case with a calcal fracture. The third very important point is a reliable team, starting with your anesthesiologist, your physician, and a team on the floor in theater as well. In my case, because I'm using a table, it is a table operator who, in essence, is becoming part of me, and we know exactly how and what to do with the leg during the procedure. And I think that is essential, especially in a way how I'm doing it, similar to Joel Mata. The AMIS system is very similar. So also the extremely important point is point of using this image intensifying theater, which you can see on the left-hand side of the screen. Then I'm having my preoperative templates and my intraoperative screening present at the time. And I'm very much so familiar, and I would suggest it to everybody to start using it, a South African idea of a vertical adjustment system that helps you to be much more accurate in a way how you're measuring your cut and your leg length discrepancy. There are other methods to do it, but this is a very sophisticated system that we're actually starting in January with international 7 countries, a study to see how accurate and how successful it is. The other way how I'm doing it, just as a tip to the people that listen, I'm using a capsule as my leg length tool. You can see the capsule is pulled distally with a suture. So when I finish with operation, I want that capsule to be able to be attached to the place where it was cut adequately, so that I know that my tension on the capsule is equal. In my own way how I'm doing it, which lots of people think it's useless, but my hands works, is basically using a simple measurements with a third point, on a wall or some static positioner, that I can see the difference in the leg length before I start the operation. Following that, the 5th point is after the surgery. Extremely important. I always say to my patients that my job is 20%. 80% is patient together with my rehabilitation team. And in 2009, we started with a program that actually ended up having a system that we're using around different practices of physiotherapy, having a specific functional assessment, following with a biokinetic assessment on a later stage after 3 months post-operatively. And it definitely improves the success of the surgery in general, and basically the happiness of the patient post-operatively is much bigger. 5+1, we mustn't forget education. And I must be honest, there is not much of difference between us and Europe or other places in the world where I had the chance to operate and on the cadavers. I mean, on the right-hand side, there is a Tiger Bird Center that is actually incredible. And I think that in the future, with all of those problems with the COVID pass, we have to try to interact with that kind of a educational program as much as possible. So this is from me, and let's start with the program. I would invite Dr. Johan Botter to tell us about his experience with the templating. Thank you very much.
Thank you very much, Chuck, for the introduction. I just got a short talk on hip templating. Just got a few slides prepared, and then we'll just do a live templating and maybe just highlight 1 or 2 items. There's just so many variables, you can't discuss everything, but maybe just a few principles will come to the front. So Benjamin Franklin said, by failing to prepare, you are preparing to fail. So firstly, our goal in templating is to restore the anatomy and biomechanics. And the plan is to restore as much of the normal anatomy as possible, your center of rotation, leg length, etc., within the envelope of what the patient allows and within the envelope of the implants that's available to you. The second point is confirming your implant size. It's been shown to be very accurate, especially in the acetabulum. Approximately 98% accurate if you use within one size. It's slightly less accurate for the femur, but still accurate. And the last point is there's ample evidence out there to confirm that it improves your accuracy That also has been shown to improve implant longevity, patient satisfaction, and less likelihood of complications. There is, however, always this warning bell that could ring, which you should take note of if you prepare preoperatively. So just a note on magnification, which is always a question. Remember that we often use, it's been recommended to use 120% magnification, and it's been well shown that most radiology departments will stay within this margin. However, there is variation. There are variation between departments, and it's probably worthwhile to see what your average magnification factor is. But it is still quite accurate. Other ways of calibrating is using the contralateral total hip head diameter. There's also the coin and the ball that you can calibrate, but there's still error factors, present here. The point is determine your magnification factor, and you will be pretty close in most of your cases. The next point is just your X-ray quality. Obviously, you want to see the whole pelvis and not, in a symmetrical way. The beam centered either on the symphysis pubis or just above. And you would like to see at least the proximal third of the femur. The femur should be slightly internal rotated so that you just see a small part of the lesser trochanter. That's just a note on X-ray quality. You can't template a bad quality X-ray. And a great plan is only as good as its execution. And tonight we'll hear from my colleagues how to execute, hopefully, a good plan on your road to success. So this is the X-ray that we're going to template, and let's go through the template quickly. Firstly, if you can see on the right-hand corner, there is let's first just start. This is a 43-year-old female. She's got a bilateral hip AVN, and she's a length is, she's a height is 1.64, and she weighs 70 kilograms, so fairly standard. And just looking at the X-ray, it's fairly decent quality X-ray. So we will have to template to actually see if there's any issues here that you might encounter. So the first step is just to customize your magnification. I use 115%, which we will just leave at that. The next step is to draw the horizontal axis. You can either connect the teardrops or the ischiums at the bottom. I'm going to draw a Hilgen-Reiner's line to connect the teardrops. You'll see that the pelvis is slightly oblique. The next step is to just draw the axis of the femur. We are templating the left femur. Right, and the next step then will be to identify a fixed point on the both femurs to decide on the leg length. I will usually use the lesser trochanters. You could also use the tip of the greater trochanter or even the neck. I'm going to use a lesser trochanter. Although you can't see it well, I can see the sclerotic line there, and I'm going to select that because it will keep the headings out of the way there so we can see the template better. So I'll select the right hip and the left hip fixed point. And you can see there's just 2 to 3 millimeter leg length discrepancy here. The next step is to identify the proximal femur. So I'm just going to run it from the saddle. I'm going to approximate, aim for my femoral neck resection, and then just outline the proximal femur. This program represents more or less conventional templating on film, which is quite nice to use a simple type of program. Right, our next step is just to bring our cup in. Sorry, we've got a slow Mac here. Right, I'm going to select a VisiFit Trio cup.
While you're doing this, if I may ask you, while you're working the question, does it also exist for the Windows users?
No, this is a Mac only program.
Okay.
So right, I've got my cup selected here. I'm going to select the size 46 cup. I know it's a small hip. The cup is brought in at an acetabular index of 35 degrees. I'm going to just correct it to approximately 40 degrees. I'm just going to do the correction. Right, and then my first step is just to overlap it over the femoral head to see that I'm not smaller. I just want to be slightly bigger than the head and see if the cup follows the contour of the acetabulum. So this is going to be on the small side, so it might be a 46 or a 48 cup. I'm going to position it roughly on the ilioischial line. As you will see that, you know, if you go down to the floor, you are so close to the medial wall that you could protrude. So you got to be so careful here to not ream too deep. And I would rather stay short of the floor and in the region of the ilioischial line. Right, we'll leave our cup there. The next step is our stem. So I'm going to just select a standard quadrilateralized stem, as some have suggested they will use a lateralized stem, uncemented. And I'm going to use the smallest I've got, is a size 1. I'll bring the stem in, and there's a huge surprise there. You can see there's no ways this stem is going to fit this canal at all. If I look at it, I'll have to, you know, bring down there, you know, to get it anywhere near. You'll increase the offset. You'll have a massive increase in leg length. So a standard smallest stem in this range will not be the stem to choose. So this is a warning bell going off here. There's something that we need to be aware of here. I'm going to just delete that stem quickly. So obviously we'll have to go for a much smaller stem. The smallest in this range is a 00 in a standard offset. And I'm going to go for a slightly shorter stem, the Amy stem, in a standard offset, which is essentially the same profile as the quadra, with a slight cutout for the shoulder and a slightly shorter tip. And now I have the ability to select a 00 stem. And I'm going to bring this one in. And as you can see here, that you know, we're closer to getting a fit here, but we're still extremely tight. I'm going to position it more or less where I think this should be, and that is 5 millimeters above my lesser trochanter. You'll see the markings there indicating about 5 millimeters above the length of calcar above the lesser trochanter. You see if I use a small, the first dot is a small head, I'll have a correction of about maybe 3 to 4 millimeters of leg length. And you'll see my offset is slightly less. What I've realized with small hips, that you have to underestimate this offset. If you go for the full offset, you will end up with more of an offset than what you want. And that's because of the geographic disturbance that you see with X-rays. The further you get to the lateral aspect of the X-ray, the more disturbance you'll have in sizing. So I'm going to go for this stem then and finish up with a standard head. And you'll see there that we've increased the length with a few millimeters, and we've lost maybe 5 millimeters of offset there. The bottom line here is if you don't order reamers for this case, you're going to be in trouble and you're going to have a long day in the office. So that's basically the point that I wanted to make, so that you are prepared and hopefully stay out of trouble. Thank you very much.
Thank you, Johan. Thank you very much for showing us very interesting problem, which unfortunately we all learn on a hard way, as you say, a long night in office. But yeah, having a backup system is one of the safety points in my book, and reamers is very common in that spectrum of equipment. I would like to ask Jan. Jan, thank you very much for your talk. You're going to introduce to us Amy's technique of anterior approach, please. Just to remember, Jan is probably, not probably, he is definitely the first user of anterior approach in South Africa, at least Amy's approach. And we started together sometimes in 2006, if I remember correctly. So over to you, Jan.
Thank you very much, everyone, and thanks, Chuck, and the organizers for inviting me to share my experience. The direct anterior approach came to us, we started in 2007 or 2006, more or less, Chuck.
Yes.
You know, to me, this essentially was a departure from the norm. And since very few other people were doing it, I was very circumspect and concerned about doing this. The dreaded learning curve was ahead of us, and the people that taught us all told us about this. And I want to thank specifically Earth Medical and later on Advanced Orthopedics, who were at the times the Medacta representatives or agents in South Africa, and they did a great deal of inputs to teach us to do this direct anterior approach. And I was taught initially the Amos method with the table, and we were all aware of the micro-hip and the figure of 4, and I went to quite a lot of effort to learn to do it without the table as well, but always found that the table for me was a little bit better. Now, there's several different tables available these days, and I use either of these, the Hannah table, Etwheel's table, and the Medacta table. We used different prostheses with this, but essentially mostly fully HA-coated stems. And interesting, the Medacta prosthesis is a hemispherical cup, and the other implants that we use is an elliptic cup, the Medacta cup, and the others are hemispherical, but they work much the same for me. Essentially, we all know the direct anterior approach is muscle sparing. It provides us with good stability, early and good recovery. I believe there's a long-term benefit for the patient and the function. Certainly, this allows me accuracy in terms of my surgery, but most importantly, it's the reproducibility of this procedure. Now, to be able to be reproducible, you need to effective acetabular exposure and femoral access. Now, standard selected, uncomplicated patient, I don't think this is too much of a problem, and most people are taught by this. Femoral access is the critical issue and the most difficult part to achieve. And that we get by external rotation, adduction, and extension to get past the iliac wing and down the shaft of the femur. I believe the table allows me to do that because with the table, we can achieve stable, controlled, constant force on external rotation. I rotate the knee with my hands, and the technical assistant, which is very important, follows with the table, and then lock at the point where we want to be. And then we can affect extension and adduction to increase or to improve the access to the femur. The standard uncomplicated cases, I think we've spoken a lot about that. You diagnose the patient, as Johan said, you must template. I think it's critical in all hip replacements, but more so with the direct anterior approach. And once you do the procedure, it should be fairly effective and look a bit like that. The issue is the difficult, complicated total hip replacements. And we all start off by selecting our patients and avoiding BMI, stocky muscular patients. We managed to identify the the short femoral neck, where we measure the index of the femoral neck relative to the head diameter. You can easily identify large prominent obstructive trochanters, and those are particularly difficult ones, and then unusually stiff hips preoperatively. But there's this joker in the pack, and it's the unexpected tight, difficult hip. Often, none of these previous criteria that we use to identify them helps us in identifying these cases. And unexpectedly, you find a case that is really very difficult and gives you a lot of gray hair. And the importance is, if you have the table, I think that helps you a lot. Now, just looking at the standard hip replacement, we do it in the prone position, which allows good access to the iliac spines and orientation of the patient. Always mark the landmarks still today. We then put the leg in the leg holder. I'm a stickler for templating. I don't operate without templating, and we also use this very vertical measurement system that Chuck spoke about. I think it improves your achievement of and restoration of leg length. Then the skin incision is done according to our landmarks. You achieve, interestingly, 3 different fascia layers until you get to the fascia over the tensor fascia lata. And then if you mobilize the tensor fascia lata down to until you get the anterior circumflex vessels, I ligate the vessels and then resect them and keep them on a pedicle. And I'll speak about that a little bit later. We restore that fascia layer as well. I then only partially mobilize the fat pad. Previous days, we always removed the whole fat pad or lifted the whole fat pad up, but just the interval where the fat pad and iliopsoas intersects, I need to identify. And then I try not to open the fascia over iliopsoas. I think anterior impingement is an issue with joint replacement, specifically with the direct anterior approach. And if you can preserve that fascia, you only need to know more or less where it is. We insert a Homan medial to the femoral neck, and in that section, obviously, you have to expose the iliopsoas, but a little bit higher up, as you can see over there, we try to preserve the fascia layer over iliopsoas. We then do open the capsule, remove the femoral head with the corkscrew after resecting the neck, and then this is once again this vertical measurement system, and this gives you a very good numerical way to determine leg length. I think determining leg length has always been a little bit of an eyeball. You get the idea, and it's a bit touch and feel and experience, but with this method you can actually measure what you intend to resect, what you have resected, and adjust the implant that you need to use to restore leg length. I think it's a very handy tool and something that people should seriously consider. We also intend doing a series on this. We then insert the modified Charnley retractor. And I take care to, and you can see this is the capsular flap with the holding suture in it. And we insert a swab between the tensor fascia lata and the capsule before we insert the second blade of this modified Charnley retractor. And this protects the tensor fascia lata muscle. I think this is a fairly frail muscle, and if you don't protect it, you can easily damage it. Tissue management is critical with this procedure, as we take so much care to preserve all the tissues. I think this is a small little tip that helps a lot to protect the tensor fascia lata muscle, and very often we have no damage to fibers at all. This is the access you have to the acetabulum, and you can, as you all know, we got good access. You resect the labrum, ream the acetabulum, template it, and then place your definitive implant, and there the implant is visible. Secondly, we then effect the external rotation and anterior deliverance or displacement of the proximal femur, and here you can see the cut surface of the proximal femur, and we release the capsule superiorly and posteriorly from the medial aspect of the greater trochanter. You go sort of halfway down the neck and then up towards the trochanter, and if you then effect extension and external rotation and extension, you can clearly see the greater trochanter elevating to the level of the acetabulum or just a little bit above it, and then you get very good access of the proximal femur to start with your reaming. You insert the starting reamer, sequentially rasp until the size we look for, and then you use your final rasp as your trial. And then we effect, it's a little bit out of focus in the picture there, deep, also as Chuck mentioned, or this is iPhone photos taken with the iPhone. There you can see a little bit of laxity over the joint after the correct implant was placed. There need to be that degree of laxity in most cases. We then insert our definitive implant, reduce it, and once again there that same degree of laxity is visible inside the joint. I then suture as you remove the femoral head, there's a soft tissue flap that comes off the posterior aspect of the femoral neck. And in this flap, the vessels that supply blood to the head usually gets torn off as you remove the head. I then suture that flap onto the over the shoulder of the implant onto the anterior remnants of the capsule. And I think by reducing this flap and putting it under a little bit of tension, you certainly reduce the amount of bleeding that occurs from those vessels. Initially they don't bleed, but I think often those sort of damaged vessels that are not taken care of at a later stage might start bleeding and cause some hematoma. And we then close the capsule, closing up the interface between the joint and the iliopsoas muscle, also once again to try and prevent iliopsoas irritation post-operatively. This is just a slide to show little damage to the muscle, and then we close the fascia and the skin. The difficult and complex cases, and I think this is the issue about the table. I think this allows you to start doing cases that are a lot more challenging than just a standard lady with soft tissues that rotates easily, requires minimal releases. With these cases, this patient's hip was, she's very short and stocky with a BMI of 40 and only had 10 degrees external rotation, and one can achieve these replacements with ease. This is I think it was a 21-year-old boy with severe Perthes. We had a very stiff hip, and we managed to effect a very nice result with this. This is also a 16-year-old Down syndrome boy who also had a very stiff and shortened hip, and we managed to restore the leg length and achieve a good positioning of our implants. This is a dysplastic hip that is also very stiff and difficult, and the sort of case one possibly would avoid if you don't have the table. Bilateral resurfacings, we've done a lot of resurfacings, revisions, and you effect a very stable and reproducible positioning of the implant. This 31-year-old gentleman has subsequently done 2 or 3 epics after his revisions. These were severe dysplastic hips, and interestingly, in this case, we also used this 3D technology to determine the exact size and shape of our implants, and we managed to do this without much difficulty. This case was virtually ankylosed hip, and we used a part of the femoral head to reconstitute the acetabulum and the center of rotation of this hip. These were virtually also ankylosed hips. I think this case was done separately, but we also used a graft in the acetabulum on the right side. This lady recently had a dual mobility hip, 78-year-old lady whose hip has been dislocated for 5 weeks, and she had this acetabulum with a lot of defect. We did CTs to determine that we have enough acetabulum to do this, and we managed to do this with acetabular augments, and she's mobilizing well without much difficulty. Interesting, this hip was quite mobile intraoperatively. The important thing is, I think the direct anterior approach with the table is ideal for standard hip replacements. We all know it affords very good exposure. We get constant, the table is a constant, reliable assistant. when you affect rotation and extension, you exert some force on the femur. And if you can do that under control, turning the knee by yourself, and the assistant, the table and the technical assistant locking the external rotation in that particular position, you don't have variable force. And I think the risk for fractures and complications like that should be significantly less. There's multiple variations of these tables available to suit your own preference, but the most important thing is to have a very good technical assistant. And I think when one explores these things, you must remember we're looking at a new paradigm. There's a lot of changes in terms of joint replacement with the direct anterior approach. I think you need to empower yourself with exposure to as many people and as many different ways of doing this as possible. And if you haven't seen how it's done, I think then you don't know. You need to be brave to embark on this journey. I think you critically need to select and plan. And now with all those previous cases that we try to avoid, we now do all comers. My greatest challenge and fear is patients with severe osteoporosis. Interestingly, often these are the femur neck fractures, which in academic institutions are used as the sort of go-to patients for teaching the direct anterior approach. I think those do pose some challenges. In my hands, I think this is reliable. It is definitely reproducible. It allows complex surgeries. I think the learning curve will be with us, and you need to pay attention to that. You need a good technical assistant. And I want to thank specifically Gerald Stein, who's been working for me as a technical assistant for the last 12 or 13 years. And I have a very regular surgical assistant, Leon van Sale, who also contributes greatly to me being able to do the things we do. Thank you very much.
Thank you very much, Jan. Thank you for your input on AMIS. I must, we're going to see now how the other way of doing DAA is, and I would introduce Henny Bosch. Please, if you can give us your input on microhip and what did you learn from Marcus Michel? Thank you.
Thank you, Chuck. Can you hear me?
Yes, clearly.
Right. So yes, from my side, disclosure, I'm the consultant. My big dream with this whole anterior approach is that I would like to do a perfect hip, and I don't think I've done it, but it's still a big aim, and I think we all want to get to an idea of a forgotten hip. My journey normally started, I'm part of the Hip Arthroscopy Society, and around you guys, Chuck and Johnny, and then all the guys internationally, you suddenly realize, but old guys like Richard Field, who's in Guy's Hospital, would also change from his posterior approach till here. You thought, listen, something is going on here. Anyway, this slide was actually the key for me when I realized I can get into a hip in the intermuscular and interneural plane and sort it out. And it's important to look at that number 4, because that number 4 means there are 2 different ways of doing an anterior approach. You can either go to anterior approach, and everyone draw this picture, but they don't really know if they are doing the one anterior to number 4 or posterior to number 4. So we all get told that we preserve all the important muscles, but it's very important that to realize that you don't see the gluteal muscles. And for me, who's still doing hip arthroscopies and to look at a lot of the soft tissues, I think it's important to realize that you're not going to see that. Although Marcus tells me he can see that and sort it out, I can't yet. So the 3 ways has been explained. Jan is doing the traction table. Hein is doing the figure of 4, and I think at Tigerberg they're mostly doing the figure of 4. For me, the main thing is that you tend to really have to get the femur forward in all these ways to do the hip. And for me, it was, how can I do a more soft tissue spurring and that I don't have to do a full capsular release in everyone. And the question is if you are sometimes doing a Watson-Jones approach. So I'm on the side, I'm standing in front of the patient, and I'm breaking the table. I've listened to a lot of guys' opinions, read papers, but I went to the guys as well. And I think it is worthwhile to spend time with them. Marcus really, while he stayed in South Africa, really helped me to perfect the technique. For me, it's very much not to do a posterior approach from anteriorly. And when you are learning, It's so easy to do that. Jan was just describing something about the posterior capsule, which he wants to suture again. And I think that's the main thing for me, is that I can sequentially release this capsule as necessary. Just look at this slide. It's important to know that it's a Smith-Peterson, you're going anterior to the tensor, and with the Watson-Jones, you're going posterior. And why is that important? Because with that purple one, you will see that there's a superior gluteal nerve, which is hanging on the top there. And that can damage the tensor muscle. Now, the tensor muscle is like the deltoid of the shoulder. And you don't really want to damage that, because you will preserve the soft tissue. But if you damage that nerve, that will not work. I wanted to show you some MRI pictures, but I don't think we have time for that. So the micro hip, which I'm doing, is a Smith-Peterson approach from anteriorly. And why the lateral decubitus? I don't use a traction table. These things are expensive. I'm not really linked to an implant. I can put any implant in through that. I can do my capsular releases according to the patient. We get stiff patients, we get lax patients. I don't want to do a full capsular release on a lax patient. The acetabular position for me, I'm normally a posterior guy. I found it difficult, like Hein was always operating on his back, the patient's on his back. And I think that's logic for him with the figure of 4. For me, I was on the side, and I battled to do the position of the acetabulum. And then I'm doing a personal a Smith-Peterson approach. So my incision is, I'm standing anteriorly at this stage. You'll see the iliac crest, and then you'll see the greater trochanter. We'll do a cut there. And what's nice is that you can always extend the cut if you ever have a problem with the femur, that you don't have to do a separate cut. So you can really go there. And I've done revisions with Marcus through this approach as well. And you can extend it easily. What is the key to this surgery is this incision of the fascia. It's really a paper-thin fascia, which you really will dissect. This is a dissection Johnny is doing on a cadaver, and you can see how nicely that is, and then you can really just look. So we're looking from anterior to the patient, and you can really go down onto that tensor. Sorry, it's now, anyone just put your finger around that. We'll use normal standard retractors, nothing special, and Homans and number 24, 26 of the stabilis, and just do a capsular T-cut. Understanding I'm standing anteriorly, away from us is posteriorly, and that's the capsule gets sutured afterwards. The neck cut, I like to do just a standard neck cut. There are people who are doing hamburger cuts. Hamburger cuts is very nice if you want to take it out, but the problem is you will have a lot of small pieces of bone in the hip, and which is not so nice. And I can use the medial calca to lever on the anterior edge of the acetabulum to get the head out. We all use have different ways of removing our femur heads. The acetabulum I can nicely visualize with this lateral or patient on the side, like my posterior approach. I can see my labrum, I can see my transverse ligament, and orientate the cup accordingly. We all use special instruments which is offset so that we can do this surgery. I think that's all the same in all these surgeries. On the side, I will use a pocket, and when I started off, I used 2 assistants, and that was a problem later. And I'll explain that to you shortly. The femoral part, I can really play with it, and I get quite a nice approach. I can manipulate the leg according to the patient, and we can go up and down on the table, and my assistant just literally put the leg in the pocket, and we can get a nice view there. Further on, it's all the same, although I can now, since I'm looking from anterior, see the acetabulum of the femoral tip quite easily, and we use a needle in that area, which we normally measure the distance from the tip of the trochanter to the tip of the prosthesis, and we can measure it here with that needle, and it's quite accurate. And I must say, this is the way I've done it, but I've also started to play with the measuring device, which is quite nice, and another thing I think it can really help you with leg lengths. We're not going to compare incisions here. From my side, the biggest problem was then we have this global freeze of a stop timer, and I think we're all now at time 0, or the more or less the same as the posterior approach. I had 2 assistants, and that's where it started to become more pricey to do this micro hip. So I walked into the shoulder surgeon's theater and realized they've got a nice arm which is for free. They are using it, and I can just go and get it. You just have to sterilize that part, and that piece of plastic on this area cost 80 Rand. So now I can just, and I just take a normal swap and tie it around that thing, and I have another assistant which don't get tired and don't cost any money, or 80 Rand, I guess that's it. And I can manipulate exactly where I want it. So I think from my side, there was a learning curve, and I think that was the big thing. But then I started comparing my patients and measured them as well. And I realized that my posterior approach is not without error. But all of them, this whole thing has really caused me to improve all my surgery. I want to state again, we don't see the gluteus, and the stocky build patients I'm still wary of. We've been measuring our patients since we started with this anterior approach. We did the WOMAC scores and now recently the WHOOS as well. And my biggest thing was to say, listen, can I improve this patient, and is it really better? Because everyone is talking about the first 6 weeks. That's not where I was aiming. I was there, which I would really say, can I get this patient to be functional and really continue? And as you can see, there is a difference between my posterior and my anterior approaches. That's ones without dual mobility hips, which I sometimes use in trauma patients, posterior ones, although most of my trauma cases now is anterior approaches. The nice thing, and this is what I didn't expect, is that when comparing with my posterior approach, that patients would continue to improve to absolutely some wonderful level. And it's quite nice to get a picture, a thing like this a week ago, to say just, I think this patient has got a forgotten hip, and that is the big aim with this direct anterior approach. Thank you.
Thank you very much for a very nice talk. And I'm glad to see that Socrates is paying out. Very nice results. Congratulations. Very, very good. I would like to call Henny de Jong, please, if you can tell us about De Vita technique, as I call it, because a long time ago, I visited Dr. De Vita, who was a kind of a father of this approach. Unfortunately, he passed away many years ago. But tell us what you think about this different approach to the DAA. Thank you.
All right, yes. Can you hear me?
Yes, clearly.
Okay, great stuff. Thanks, John, for the opportunity. Thanks, Koos. Thanks, Michelle. Okay, so I understand time is an issue. I just need to advance my slides. Somehow I just can't move the slide.
Use the arrows in a
right, there it goes. All right, there it goes. Okay, look, as Eddie said, I was used to anterolateral and modified Harding. I was taught by a guy that did his teaching of his fellowship with Sir Charnley. So it goes far back, and it was probably time for change. But we operated them all supine. As they said, we operate them as they lie. But it worked well for us for over 20 years. So we were under the influence of the Americans as well. And Adolf Lombardi convinced me every year that you can do outpatient hip replacement through the anterolateral approach. Then, like you said, Jan was one of the pioneers. He phoned me more than 10 years ago asking me what I think about this. I told him my reaction was the same as Dr. Moketi. He said, no, it's not broken. Why do you need to fix it? Anyway, so Jan came to my hospital, and then it was quickly evident that these patients were dancing in the wards day one, and mine was still shouting for painkillers from the bed. So there's definitely there was definitely a place for this thing. We started looking to go more anterior. We published or presented this article at the 2011 Arthroplasty Congress, where we looked at the neurological supply of the tensile fascia. So we soon realized we had to go over the tensile fascia and jump into the pure intermuscular plane. At that stage, I was also at the Tygerberg Hospital, and we thought that a traction table might not be available on a Monday morning due to the trauma load, so we had to look at something else. These are my instruments. Keep it simple. On the left side, just the offset femoral approach. You need an offset acetabular approach. I use a straight acetabular impaction to avoid losing power. I use some curved instruments, which I will show you soon, to get access to the proximal femur. just a couple of homers. This Norfolk, Norwich is quite important in the technique that we use. And we use just a simple Homan, which is a bit adapted with a bit of a weight on the side. I've stopped using the femoral elevator. It tends to make a little bit of a more soft tissue damage. This is a theatre setup. I suppose it takes a bit longer than the traction table. I would say 5 to 10 minutes. We clean the operating side, and we only clean on the contralateral side, the proximal area. I use one assistant. He needs to be there a bit earlier to help with the cleaning. Our bolsters, just the only addition is this extension on the contralateral side, right about the knee height. I will show you later where I use that. As I said, one assistant is standing on the other side, and when I start with the femoral work, he comes to my side. The incision I'm not going to talk too much about. We obviously, like Johnny said from his experience, we took it a bit more lateral to avoid the lateral cutaneous nerve. If I have time, I'll show you something about the bikini incision later on. So I always tell the guys that come and visit me, if it doesn't look right, it probably isn't right. It's one of your safety tricks, I suppose, Chuck. So you go in there, you must see the fascia of the sartorius and the rectus on the medial side. You must see the vascular bundle in the middle of your incision. One of the tricks is just distally to the neurovascular bundle, just make a small cut and drop your finger in that fatty pouch, and you're on the fat and the quadricep. Just go a bit more proximal with your finger, and then you must feel ilium. If you don't, then you're probably medial to sartorius. I suppose that's one of your things that you can add. The capsulotomy, I hope you can see the video. The capsulotomy, I do a little bit different. I do a lateral capsulotomy. I find my iliacus capsularis, and then here I follow the crista, and then I open it up on the lateral side with my 2 Homans extra-articular at the moment. I've started to throw it medially because it was too much abundance on the lateral side, and I feel the tensor fascia is protected by a simple swab that you can see here. You don't need anything more than that. And here you can see me going intra-articularly with the Homan. Getting the femur head out is not that difficult without the traction table. This is a technique I use. Just go into hyperflexion, and then it pops out. If you struggle, just ask the assistant to give the leg a little bit of a pull there. Okay, another safety tip that I can add to your list, Jack, is stick to the basics. Just because it's a different approach, I think when you especially do your acetabular preparation, just continue with the normal things that you do. Remove all the soft tissue on so that you can, you can see removing the labrum, so that you can identify the anterior and posterior rims very, very properly. Here you can see my retractors in the medial side, just over the edge of the transverse ligament, and I use my Norfolk retractor here. It's resting on the femur in the distally and approximately just on the anterior tissue. If you have difficulty getting access, then the first thing I do is to go and look at my femur neck, and maybe it was cut too long. The second thing is then, and most guys, I know Koos and the guys talk about this at the routine, to start, before you do your acetabular preparation, don't do your femoral elevation, your femoral preparation before you start with your acetabular work. Okay, yeah, I like to, because the space is narrow, like to insert the reamer on its own, and then, as I said, you use an offset acetabular reamer to avoid anterior bone destruction. Another trick that I've learned is to put the cup in on its own and sort of use a punch just to position it sort of nearby, and then you insert your impactor. Just make sure that you don't start to impact it before it's in position. And this is, I suppose, one of the things that I like the most of the way that we're doing it. So I've got the fact that the patient is lying supine, flat on the bed, and I've got control over this pelvis. I feel comfortable and safe doing this. I can aim. I use the table. I know where my anterior iliac spines are, both of them, and I can easily aim for my 10 to 5 degrees anteversion by using the table, as well as the 40-degree abduction, but I still combine it with my anatomical landmarks, the transverse ligament and the bone, anterior and posterior bone. So femoral elevation, that's probably the biggest or the most important part if you do it without the traction table. You guys make it look so easy. So we had to dig it a bit deeper. So work done by Solomon, etc., a lot of guys, presented by Kutan at the Academy. So what they found is that basically the superior capsule is the key. But what they also found is that at the superior capsule, it has adhesions from the piriformis and the conjoint tendon made up of the obturator internus and the gemelli. So we always think, if you look at a picture like this, that there's the medial calcar and there's the greater trochanter. So you always think that the muscle that you see or the white tendon that you see there is the piriformis, but it's not. It's actually the obturator externus. So essentially, when you do the superior capsule release, then it flips over. It basically takes with it the conjoint tendon and the piriformis. So the purists would probably say that we're not really just doing a superior capsule release, but we do probably a little bit of a partial external rotation thing as well with the piriformis and obturator. But that's a topic for another day. So I start with this position with the leg on top of the other one, and now I can evaluate the inferior capsule and at the same time the lesser trochanter. But it's rare that we need to do that anymore. So we let's focus on the elevation. Two techniques well known. So they use this the dislocation hook to just hook it in underneath the medial calcar, but I rather just use my normal Homan gently underneath the capsule there. So this, I hope the videos. This is two examples of me doing the superior capsulotomy. And you just go through the capsule until you get that fat pad, and that's now a well-known or accepted anatomical landmark between the superior capsule and the gluteus medius. So that's, I suppose that's all you need to do to achieve this. So this is what you are working towards: the elevation of the proximal femur. So you can see it comes up, and you should not use too much force. If you use too much force, then you're not ready to do the elevation. And you can see here on the right hand side, the elevation has been done with the leg in a neutral position. So you must achieve this. You must achieve this before you proceed with any procedure or for the rest of the procedure. And that's where you go after you've achieved that. You go into your so-called figure of 4, which is not really a figure of 4. It's a modified, I suppose, with the knee not in flexion you must, otherwise you tension the plantar fascia too much. And this is where that extension on the contralateral side of the femur comes in very nicely. So femoral preparation, I want to be quick here. So I use some curved remus just to find the canal. One of your safety tricks, I suppose, again, is to, you must, before you go further, find the canal. You can't hope that you're there. The suction tube is always a nice way of finding the canal as well. Femoral limb, I see that was one of the questions in the chat room. Finding the anteversion on the femur, is it difficult with the supine? I don't find it. I understand what the question is about. It's too much medial tissue. So two things there. The one is that you should probably then use, if there's too much tissue in an obese patient, use a double offset reamer, number 1. Number 2, then we can argue that the release, the femoral release is not optimal. But I find it very easy with the leg lying in front of me. I know where the knee is, and I can see the leg so that I can aim that I'm very comfortable and safely can determine the anteversion on the femur and have a clear view of the medial calcar. So, but I suppose this is the key to well, the thing that I like this technique the most about is the stability testing. So I can easily, I've got the leg in control. I know where my pelvis is. I know where my anterior superior iliac spine is, and I can do a proper chuck test, except 1/2 to 1 full length width of the femur head. We use a 32 size head. I do my anterior testing and I do my my flexion, adduction, internal rotation. This makes me feel very comfortable and very safe. The fact that you use an anterior approach, that doesn't mean that you can't dislocate. So this is a clear example of a posterior dislocation, sinking feeling. I have to go back to the basics, and we combine this with a leg length measurement. So again, I can feel my anterior iliac spines very clearly, and I do a proper true leg length measurement. You can do Galeazzi, whatever. Once again, it makes me feel very safe and comfortable. Couple of tricks on the left-hand side. When you've done your trials in how you want to dislocate, I've seen, when you dislocate, I've seen this trial head disappearing medially, never to be seen again. So the tip is to keep your finger on that head when you dislocate. When you femoral impaction, the prosthesis, make sure that you keep an eye on the medial calcar for any cracks. And as both speakers alluded to, using the capsule as some form of idea of leg length when you reduce of a leg length discrepancy that you created. The bikini cut is something that I'm starting to use more and more. You do it along Langer's lines. You do it just below the skin crease. It's proven to be if verticosmesis and less proximal wound problems. And I find it, as it was said before, the chance of lateral cutaneous nerve is not more than the longitudinal incision. Just remember there's more abundant tissue anterior of the distal femur, so be careful when you do your acetabular rimming. Revisions, definitely a highlight for me. This is a trick I've learned. You sometimes get the difficulty to get ahead of the femoral prosthesis. Give it a bit of a pull, and you knock it off in situ. Then you reduce it. You dislocate it, and you can get the head off easily. And this is the position I use when I do my acetabular revision work. I put the femur on the other side, and that makes the neck nicely tucked away, posterolaterally out of my way. This is not I'm not going to say it's a better way of doing it. I come from an anterolateral approach I've used to operate patients supine. But as Dr. Makete said in episode 1, we are going for perfection here. I mean, it's already a successful operation, and we have to look for small things like impingement of the prosthesis, ellipsoid irritations. That will give you the forgotten tip that Danny talked about. Thank you very much. I hope it wasn't too long.
Thank you very much for your input. There was a very interesting videos and some tricks that you're using. And it seems to be that we all getting to the same goal, that we're trying to do as muscle preservation surgery as best as possible. So I think we can start now with a little session of questions and answers. We have about 10 minutes to do that. And I will just turn back to what I got from the Q&A on the system. There was one question about the anteversion in supine position. Before I go back to you guys as a panelist, I would say my experience on the table, one of the tricks that I was using before start using a CM is a kind of a confirmation of my cup position first and foremost, was basically that my inserting instrument of the acetabulum component was more or less about 5 degrees away from the horizontality of the floor. So that works for me on a table. My question to you guys in the figure 4, let's start with you. What would you say? What are your points of positioning the cup in a proper inclination inversion when you're putting it in your position of figure 4? Because obviously you're moving the pelvis in a way when a patient is supine by moving the leg, and so what would you say? Where's your safety belt in the positioning the cup besides using a C-arm? I don't know if you do or not.
Basically, yeah, I feel again that if the pelvis moves, I will know about it. So I make sure that I keep a close eye on the anterior superior iliac spines. So and I feel and that's an addition. So the way that I would stabilize the pelvis actually, but more is to let the contralateral leg lie, well, take it off the table on the other side. So that's a trick. But I never need to use that. But I'm of strong emphasis on the anatomic landmarks, your anterior posterior rims, and your transverse ligament.
Thank you. Henny, what would you say? Because you're looking, in my view, you're looking into the hip upside down. I know that it's a brilliant technique, but I mean, it's the same like in a hip arthroscopy, when you're looking, Philip, on you're looking upside down. So that's the way how you're doing this hip for the mini hip. But what would you be your landmarks as well? How do you turn from posterior to the anterior?
So I can see the transverse ligament very nicely, and also the posterior labrum. I remove some of it, but not everything. So I leave a lip of posterior labrum posteriorly. And then anteriorly, I can palpate nicely because it's just down on my finger, the anterior lip. So I would normally just see that anterior lip is not sticking out at all. Obviously, dysplastic patients is a bit different, and it's strange. Although they sometimes stick out, they don't get psoas pain afterwards. But that's the things I look at. What is very essential with the posterior approach, with the micro approach, is that you need a very strong posterior post and where you position it so that you can still get your leg an extension. That you don't put it too low, that it limit that. But I mean, that's very important. Anatomical landmarks and also your position beforehand. You really fix that pelvis.
Johan, would you add something to Johan Botha? You would add something for us? We're using a table. Would you say any trick about position of the acetabulum? Are you with us?
Yes, I'm with you. Yeah, basically, I'm with you, Chuck. You know, it took me a number of hips to realize, you know, X-ray is quite useful. So essentially, I use the anatomic landmarks of the transverse acetabular ligament. Your anterior wall is what you can palpate nicely. In my trial reduction, I'll make sure that I've reamed deep enough so that my cup's seated. In general, in the traction table position, you want to have the cup more closed than what you think. So if you're aiming for 45, you're going to be too open. And that has been shown by Beverland in the posterior technique approach as well. So you're going to aim slightly more closed and your anteversion is going to be less than what you think, about 5 degrees. But now with the use of the X-ray screening, it's even better, you know, so I'm just confirming my position. And I can look at my ellipse and impact my cup in a desired position. So that would be my comments.
Thank you. We have another question from audience there regarding besides the positioning of the swab, any practical tips of preventing the TFL damage? And yes, this is a very good question because I think all we know that beast is a different quality. It's a very, very, very much so muscle that tend to be damaged if you're using it too much forces. Do you guys have any tips about how to protect the TFL on the way into the anterior approach? Jan, Hubert, you show us that you're using a swab. Does anybody else has any other tips on it?
Retractors I'm using is quite soft edges. So that's the one thing. And then what I've also seen is that the movement of that retractor, and that's quite nice about this new friend of mine assisting me, he stands still and doesn't get tired.
Yeah, I would add to that in the technique that I'm using is that Jan showed as well, we're using a modified Charnley retractor, which is actually very sleepy and stable. So there's not too much motions in it. But I would say to answer that question in general is that that surgical technique is the best prevention. I think the gentle approach and gentle exposure is the trick to prevent any damage, never mind the TFL, which is possibly most prone to any damages. I would like to raise another point, which Jan Hubert mentioned as well, that is a psoas tendinitis. We all know that we occasionally have a problem of that. What do you guys think about preserving the anterior labrum as a kind of a biological barrier between your prosthesis and your cup inserted acetabulum component? Henny, what do we say?
The iliopsoas irritation is a big issue, but it's been well known that you should make sure that it's well seated under the bone. So I feel rather to make sure that you know where the rim is, take the labrum out and make sure that that cup is seated under the bone or just flush with that bone. I rather take out the labrum and that I can have a proper look there. That's my feeling.
Chris, can I ask you, you're very quiet there in the background, and I mean, you are a host anyway, so let me ask you a question about how do you deal with the problem of leg-left discrepancy?
So I'm also using the figure of 4 like Hein is doing. So we template, we start by preoperative assessment templating. And so that will be the first part. So you know what you want to achieve. And then intraoperatively, it's a combination of just, I'm doing a formal Galeazzi. So not even just 45-degree hips. I go to a 90-degree hips because then you also exclude your hip spine syndrome. So I like to go to a 90-degree hip, 90-degree knee Galeazzi. And that's for me the most accurate way that I can assess leg length. Regards psoas, just one short answer on that. I agree with Hein, and the anterior finger to feel the anterior edge of the cup is important. But you get less psoas irritation if you use a 32mm head. So if you tend to go to 36 as your default head size, it tends to create a more bulky appearance to the acetabulum, and you actually sometimes tension the capsule. And we found also that if you need to have a reason to upgrade your head size to 36. Don't do that just routinely for stability. If there's a specific reason, do. But by using a smaller head size, you also decrease that problem.
Thank you. There was another set of questions which were related to surgical technique, but to the post-operative management. We all mentioned that anterior approach give us opportunity to mobilize patient much faster, much easier, much quicker with less pain. And there was a question about weight bearing and uncemented components. Would you allow the patients to be more active in the first 6 weeks than what would you do, for example, with a hard hinge or posterior approach, or would you protect them more or shall I say classical protection rather than let them go crazy? Jan, shall we start with you? You have ample experience for almost 20 years.
I think I allow them, also you judge the bone quality during the operation. You get the idea if somebody's osteoporotic. I think one gets a very good idea, and you can see that on the pre-op X-rays as well. If somebody's got good bone quality, I'd allow them to mobilize. My guideline standard is 1 week with 2 crutches, the second week with 1 crutch, and the third week they can start sort of forgetting their crutches. Very tall, large men, I now keep on crutches for 2 weeks or 2 crutches, and then they can start walking on 1 and avoid it. They're never the ones that fracture. The people that you see, I mean, we see very few fractures, but the one that fractures are all osteoporotic ladies, and that's why I said my greatest challenge today is osteoporosis. I think we all tend to cement a lot more in those osteoporotic patients. You know, that's a way of taking care of this. If you're happy with the bone quality, I think you can let those people mobilize. I do protect men a little bit more, but not that much. And I don't have problems from them.
Heidi de Jong, what do you do?
Yes, that's a great question, Chuck. I must say that worries me. So I've changed the prosthesis before anterior to metaphyseal fitting prosthesis. I wanted to get away from thigh pain and stuff and stress shielding. Then direct anterior came, And I was a little bit more uncomfortable using just a metaphysical fitting procedure. So I went for the double taper procedures, which gives you a little bit more diaphyseal fitting. But what I'm worried about is that will probably, I don't know where it will end, but that can produce more thigh pain, I suppose. But I am worried about that, and I've changed the procedures to do that. And I do cement the severe osteopenic patients, but those patients normally I don't do anterior. So if that's one of the, if they're severely osteoporotic, I'd rather go another type of approach. Thank you.
I think we run out of the time. I was told to stop at 9:20. Gentlemen, I have to thank you for a wonderful session. I think this was great, and I hope the audience had some input and some information. They can use it in their own practices. And I would urge everybody, I suppose you all agree with me, if anybody from audience has any questions about anterior approach, please approach us, send us a mail, contact us. We will try to help everybody as much as we can. This is the whole idea of this group, to get together and to help each other and to extend the anterior approach as much as possible. And with that ending, Koos, back to you. Thank you very much for organizing.
Thank you, Chuck. Just one or two last things for me. Today was the big finale of the 4-part series. So we had the quite esteemed faculty. I promised them all a bottle of wine from my wine cellar, and unfortunately lockdown has actually drinking away most of my wine cellar. So guys, must allow me to get back to a weekend to actually, or no, the wine farms are closed on weekends, but you'll still get your bottle of wine. But we really have esteemed faculty from across South Africa. Day 3, we had the super subs. That was Prof. Chetty from anesthetics, Annette Tron, also from anesthetics, she's my wife, and Leanna Lowe, the physiotherapist for our unit, just to give us another side of this patient. And then the aims was initially to provide South African context, and that was a strong focus for us. We are not a first world country. We are also not a third world country, but we do surgery that's on the same standard of first world context.
I'm going down now.
So that was the first thing. So we want to give South African context to this, to the direct anterior approach. We wanted to stimulate academic discussion. I mean, it's good that we talk about the advantages and the disadvantages of the approach. It is not the perfect thing, but there's no perfect thing in life. So it's about good surgical technique. It's about robust training for this, and forums like this where we can discuss the common problems. We also established that we have common goals and interests, things that must work on. I must say, Henny, congratulations again for that great stats you showed us today on your outcome scores. I mean, we need to work together to show our South African patients how these things not just looks on X-ray, but also what the function is on a nice independent assessment forum. So this virtual meetings is also the start of the new normal for orthopedic learning. It was the first time that we did it on this level, on this large scale, and we've learned many good lessons out of this, and hopefully the next time we'll do this, we'll be able to incorporate all these lessons we've learned and even take this to new heights. The one thing that we haven't achieved yet is to collaborate, to create collaborative research possibilities. But we've shared our experiences, and I believe that this will be a natural progression that will go forward in times to come. Last, I just want to say from Cape Town, thank you to everybody that's been involved. Special words of thanks to Advanced Orthopedics for helping us with this. It was just an idea. We didn't thought we could pull it off, and we did. I want to say thank you to all the chairs from the different provinces that actually helped us with this, the panelists and the attendees for all the questions you should ask. I want to thank everyone for all the messages, discussions and emails after these meetings. And I think in years to come, we can still look back at our first attempt and we'll laugh about it. But I think this will be a good stepping stone for good things to come. So I graduated from UKZN, and at the library, as you walk into Nelson Mandela School of Medicine in Durban, there's this bronze statue of Nelson Mandela. And I must say, every time when we wrote the college exam, we walked past that statue, and the inscription on that statue was always, after climbing a great hill, one only finds that there are many more hills to climb. And this is so true in this case as well. So we achieve something by hosting these meetings, but there are so much more that we can do. So for it's over and out to you, Michelle, and that's the end for us.
So thank you, Dr. Jordan, for leading this meeting. You wanted a South African flavor. I think we got that. A fantastic panel, lots of great input, and we can see that there are some excellent experts around the country to share their experience in this technique. So I would also just like to thank our team, Ruby Franken and Leonie Claassen, for a wonderful job in the background there. Thank you for all the communication, and thanks especially also to everybody who's taken the time to attend. So we welcome any advice, criticism, anything that we can build on for this meeting. You're welcome to contact us, and we look forward to the next time round. So thank you. Good night, everybody, and sleep well. Thanks.